This is my fight song. Take back my life song. Prove I'm alright song. My power's turned on. Starting right now. I'll be strong. I'll play my fight song. And I don't really care.
So welcome back, folks. We're going to do the final of these, or close to the final of these videos. And this morning we're going to take on stroke. And I have Dr. Gaughen with me, who is a neurointerventionist surgeon from Santera Martha Jefferson. And we're going to talk about the new changes in stroke, things maybe that we could do best to affect outcomes for patients, and what the new research, new ideas have come up in the last couple of years. So Dr. Gaughen, welcome. Thank you for coming and seeing us. So some changes, a lot of new stuff gone on in the last couple of years. Sort of hit the highlights of the things we know more about stroke in the last couple of years than we have done before.
Tom, thank you for having me. I'm very excited to be here to talk to you about stroke and some of the new changes that we have related to stroke. The last 2 years have been very exciting years in the world of stroke. There's been some literature that has come out that has really expanded our ability to treat patients with strokes, which has led to a significant improvement in patient outcomes with that disease process. As you know, as I'm sure everybody knows, that historically the treatment for stroke, and when we talk about stroke, we're largely talking about ischemic stroke, which is blockage of a blood vessel, and that's what most of this new literature relates to. Historically, the treatment for that has been intravenous TPA, or intravenous thrombolysis, which is the clotbuster medicine that we give through the veins to break up strokes. Over the last few years, we have been able to identify certain patients within that population that actually benefit from more aggressive treatment. And that treatment is actually going in through the blood vessels to remove that clot through a process called mechanical thrombectomy. And very similar to what the world of the heart attack and myocardial infarction went through several decades ago, we're finding that the more aggressive you are with certain of these patients, the better they do. And so we can choose patients with larger blockages in larger blood vessels. We can find them quickly, treat them quickly, and have a much higher rate of those patients returning to functional independence, surviving their disease process and doing well. So it's been a very exciting time.
That's cool. Out of the percentage, I think, of people that do have strokes, and we know stroke is, one of the big killers in society. People always wonder, is it a bleed versus is it a clot type process? Percentage-wise of people who have stroke, how's that divided up in the population?
So excellent question. So stroke is a clinical diagnosis, and it really is a constellation of symptoms. So stroke is a persistent neurological deficit, and it can come from a lot of different things. Now, when we think of stroke, we think of ischemic stroke or blockages of a blood vessel, and in fact that is the most common cause of stroke. About 85% of strokes are ischemic strokes, meaning they're blockages in blood vessels, which means about 10 to 15% of strokes are hemorrhagic strokes, which are neurological problems that are caused by various forms of bleeding either into or around the brain. And then there's a small percentage of patients with stroke symptoms that actually are what we call stroke mimickers, which are patients who present with things like seizures or tumors or other things outside of blockages in blood vessels or bleeds that can cause those symptoms. So it's a fairly eclectic group of diseases, but the most common one by far is ischemic stroke.
Now, we've talked in several of the other videos, particularly about acute coronary syndromes and STEMIs, and with the trauma folks. And one of the things that they have wanted to get out very clearly to EMS folks is that this is, as their disease processes are, but this process of stroke is a particularly time-sensitive thing. And I know we know from research, and anecdotally we know from taking care of patients. Can you give us a rough idea about time frame and the amount of damage that is done? And I know you and I have talked about this, and you present this in some of the lectures you do. The time frame and the amount of damage that's being done over that relatively small time frame.
Right. So we know that stroke is an enormous public health issue. It's the 5th leading cause of death in the United States. It's the leading cause of adult disability in the United States, and it is incredibly time sensitive. The brain is a very unforgiving organ in terms of damage. And we know that about 2 million brain cells die per minute in a stroke. And so it's a very, very time sensitive process. The TPA that we talked about, the intravenous clot buster medicine that we talked about, we know that if you, in the majority of patients, they really only receive the possibility of benefit from that treatment up to 3 hours. Now, there is a small subset of patients that receive benefit potentially up to 4.5 hours, but after that time period, the risks of that medicine, which is bleeding, outweigh any potential benefits. So identifying somebody quickly, getting them very quickly to the appropriate place where treatment can be initiated, and treating them very quickly is all incredibly important because it is so time sensitive.
So for many, many years, I think certainly some of us in the EMS community, but I think it's fair to say the public, TPA has been very successful as regards public relations, and you know, known as the clot buster. And we sort of had a feeling that once you get your TPA, that's pretty much guaranteed success for you. But we know that that's not actually represented in real life practice. Can you give us a rough idea of how many people, EMS folks, and that's one of the things that we're all very, sometimes I hear people being frustrated about. We've done all the right things, got them to a stroke center, we gave them adequate time to get ready, and then the patient didn't get the medicine. So can you give us a rough idea how many people get the medicine, and then how many of them actually get this great benefit that we seem to think all people will get if you get TPA?
Well, that's an excellent question, Tom. And in fact, one of the reasons that we have tried so aggressively over the last decade plus to come up with more aggressive treatments, if you look at what TPA does for patients, those numbers are not incredibly optimistic. So I think if you look at estimates, you know, there's a large grocery list of reasons that people are not eligible for TPA because it is a drug that is administered that goes through the whole body. Anybody who has any risk of bleeding or any history of bleeding, any prior surgeries, there's a whole host of people that are on blood thinners. There are a whole host of reasons why patients would not be candidates, even if they show up in the appropriate time period with the appropriate symptoms. So what we find is that for about every 100 patients that end up in an emergency department with a stroke, only 5 of those patients end up receiving TPA, either because they don't meet the criteria from a time standpoint, or they have one of these exclusions, or they don't make it through the system fast enough. There are a whole host of reasons why they wouldn't get it, but about out of every 100 patients with a stroke, 5 get TPA. And if you look at the efficacy of TPA, it does not work 100% of the time. In fact, we estimate that about 20% of people who get TPA get better from it. So if you boil that down, that means out of every 100 patients that end up in your emergency department with a stroke, 1 patient is going to receive benefit from what historically has been the only FDA-approved treatment for acute stroke. And so for that reason, obviously that means 99 out of 100 patients that we see, we're not giving much of a treatment for. And that has really sparked us and spurred us to come up with more aggressive ways to extend the time window and treat these sets of patients that we know TPA is less effective for. And that's where a lot of this recent literature that has come out has really helped us expand the application of emergent stroke treatment.
So I think that's an important thing to know, and certainly for us as EMS providers, and I always tell people that our job is to give the patient the best possible outcome, but I think you have to be realistic, otherwise you're going to get a very sort of pessimistic outlook on how well you're taking care of your patients. Mm-hmm. It is important for folks to know that we're trying to get them there to get the benefit of what treatment is available, but this is still overall quite a devastating disease. Absolutely. For people to have. Now, of those people that might get TPA, and I know your practice at St. Martha Jefferson is not in the administration of TPA. You're an interventionalist and a clot snatcher. Your job is to go and mechanically remove these clots. Of the patients that do have strokes, is there a particular type that seems to have been proven to where mechanically going and getting that clot and removing it versus trying to dissolve it, is there a subset of those patients that present with particular types of strokes that's really good at?
So Tom, that's exactly why we have tried to identify patients that would benefit from more aggressive treatment. Some things that we know about TPA is that we know that the smaller a clot is, the smaller the blood vessel that clot ends up in the brain, and the milder the symptoms tend to be. We also know that the smaller a clot is, the more likely it is to have TPA dissolve it. So what we find is that TPA is actually a very effective treatment for patients with small clots and small blood vessels with milder forms of stroke. Now, the patients that we have been very good at being able to identify now as receiving benefit from the mechanical thrombectomy are the patients that have what we call large vessel occlusions. And those are patients that have large clots that end up in large blood vessels that present with much worse stroke syndromes or much worse stroke symptoms. So people that are completely hemiplegic on one side, unable to speak or unable to attend to half of their body. These larger stroke syndromes, we know a few things about them. We know, one, their morbidity and their mortality is higher. So a patient with a middle cerebral artery occlusion, their mortality rate alone is about 25%. Patients with an internal carotid artery occlusion, their mortality rate is greater than 50%. And people with a basilar artery occlusion, so those would be the three major types of large vessel occlusions, a patient with a basilar artery occlusion, their mortality rate untreated is about 90%.
So why is that? That basilar artery, if you're European like me, basilar artery, why is it such a terrible killer compared to the others? Certainly have big numbers, but what is it anatomically about that, if you block that off, that is going to kill you off? So
the middle cerebral artery and the internal carotid artery are also devastating stroke syndrome. So of those patients, the 50% or the 75% who survive, they still, left untreated, have significant morbidity and are debilitated. What's unique about the basilar artery is that so if your brain is the tree, your brain stem is the trunk. So it accumulates all of the information that starts and ends in the brain and communicates it with the body. In addition to that, it also has all of our autonomous functions that we possess that we don't think about. So our ability to breathe, our ability for our heart to beat, the things that our body does without us thinking about them, most of those originate in the brainstem. Now, the basilar artery is the single artery that connects both sides of the brain and the brainstem to the body. And so when you block the basilar artery, you're blocking input and output from both sides of the brain, in addition to blocking areas of the brainstem that control some of these autonomous functions like heartbeat and respiration. So these patients can present with coma, they can present with sudden cardiac arrest, respiratory arrest. So it is a very global effect on the brain and the body. So it has a very high rate of mortality associated with it, in addition to an incredibly high rate of morbidity associated with it. So, we know that giving TPA for these large blockages, TPA just isn't strong enough to dissolve clots that are big enough to end up in these blood vessels. In addition to the fact that about half of people who have large blockages in large blood vessels or large vessel occlusions come from the heart, from arrhythmias. And most of those patients with arrhythmias are on blood thinning medicines that preclude their ability to actually get IV TPA. So that half the patients that we see with these blockages wouldn't get TPA because they already have medicines that keep them from getting it.
So that's good information to know as regards, when you're looking at patients and clinically when we see them in their houses or wherever it is we see them. Can you give us just a rough idea? You did allude to smaller vessels, smaller clots versus these LVOs, large vessel occlusions, being more devastating. clinically, the symptoms you would tend to see in patients when you and I are out there seeing these patients, I think it's a good idea, because it is so time sensitive, that we need to have a fairly low threshold for presuming that this is a major stroke and getting them into a system that's going to aggressively take care of them. Clinically, the symptoms for somebody with a large vessel occlusion versus somebody maybe with a smaller occlusion in a smaller vessel. And I know you can't generalize, but just for people to be able to think, ooh, if I see this constellation of symptoms, I really need to be thinking that this is something that's, not that all strokes are not important, but.
So excellent question, Tom. And you know, stroke, unlike heart attack, stroke and heart attack share a lot of similarities in terms of some of the etiologies for the strokes and some of the treatments that we have available, the fact that we can treat them minimally invasive. But stroke is a very difficult disease because it has such a wide range of presentations. And I think the first and probably the most important thing for a first responder or a family member, anyone who's involved in that, is actually identifying that the patient's having a stroke. And we have scales that we use to help people identify strokes, like the Cincinnati Pre-Hospital Stroke Scale, to help begin the thought process that the patient's having a stroke. And obviously, the sooner that the hospital knows, that the patient's being brought to knows that there is a possible stroke, the sooner we can activate the systems that we need to activate to have that patient really put through the system very quickly. Because just like being in the field and having that patient brought to the hospital as quickly as possible, having the system in place in the hospital to evaluate and diagnose and treat that patient as quickly as possible is incredibly important as well. We are currently working on some ways to help differentiate patients who would be TPA candidates versus patients that would be mechanical thrombectomy candidates. It's important for, I think, first responders to recognize that a patient can get any combination of those two treatments. They can get one treatment and not the other. They can get the other treatment and not the one. They can get both, and they can get neither. So anytime you're seeing a stroke patient, you need to recognize that you are looking at a patient who has multiple different potential treatment algorithms, and the more we know about that patient before they get to the hospital, the better. And so some of the things that we're looking for, and someday we'll have a uniform or unified algorithm like we do with some of the ones that we use now to identify stroke, to help us differentiate small strokes from large strokes in terms of patients that would potentially receive mechanical thrombectomy versus ones that wouldn't. And that's an important decision to make, but just sort of gestalt-wise, things that we can be looking for to help let us think about that. If the arm and the leg are both involved, if the patient is having problems with their speech, diagnoses that we call aphasia, either they're talking in a word salad and they're saying words we don't understand, or they're not able to produce words, if they're neglectful of part of their body, if they aren't able to see out of one half of their visual field or the other, so neglect, aphasia, visual field cuts, visual field deficits, those signal to us that large areas of the brain are involved, in addition to the areas that can produce weakness and numbness in the side of the body. So we're always looking for facial droop, we're always looking for weakness in the arm, we're always looking for weakness in the leg or sensory losses, but things that help tell us that more larger issues are if patients have neglect, aphasia. And then we also look for things in the back of the brain that may not be as readily apparent, things like ataxia, things like dysconjugate gaze or double vision. And so some of the things that can point us towards the back of the brain, which is the basilar artery, which is an important artery that's a little sometimes harder to identify. Those are all things that should start to percolate into our thought process when we're seeing these patients to help figure out how bad we think their stroke is.
So that's all good information to know, and presuming that you figured out that people that clearly have problems speaking, either they can't actually speak words, or they're speaking words that just make no sense. They're not seeing or recognizing one half of the world from the other. They have an inability to move arms or legs or both together on one side. And obviously those are the things that we're all in training and seeing patients we're all fairly familiar with. One of the things I think that over the years, a lot of emphasis has been put on, especially in EMS training, is time frame. And we've had varying different times put out, an hour and a half, 90 minutes, thereabouts. Then folks said, well, if they're 3 hours out. And to a great extent, even though it probably wasn't intended, people were sort of told, if you're not in that window, sorry, all bets are off. You're not getting any of these many treatments that you've talked about. But really, we've seen that that's not necessarily true, and those windows are extending, and they're extending also, and we'll talk about that in just a second, for the people that we really had a problem with, which was the people who woke up last seen normal last night. But first, let's talk about the regular windows and how they're expanding.
One of the things that we've seen, Tom, over the last several years is really a push towards increasing the urgency and the acuity of treatment of stroke patients for a much longer period of time. And you're absolutely right. Historically, we've really pushed these early time windows, and if a patient didn't meet one of these very strict time constraints, that largely there wasn't much that we could do for them, or there wasn't much that we felt like we had to offer them, and so that urgency kind of went away, and that was, I think, conveyed to the emergency services, to the first responders. And one of the things that has changed dramatically in our thought process, and something that we're trying to actively educate people that participate in stroke care, is that there is there are things that we can do for a much longer period of time. And there are patients that are going to benefit from potential urgent, emergent stroke treatment for up to 24 hours. And that includes patients now that fall into what we call the wake-up stroke, where we don't know the last time that they were known well. So if you look at TPA, so let's just run a little bit through the literature that we have that kind of guides our treatment. So TPA can now be administered, according to the ECAS-3 study, it can be administered up to 4.5 hours after symptom onset. So patients with wake-up stroke still are not eligible for TPA, but we have 4.5 hours to find, identify, and treat a patient with acute ischemic stroke with IV TPA. So certainly that time window still holds true. With mechanical thrombectomy, based on the literature that we had that came out in 2015, for anterior circulation strokes, and that's internal carotid artery or middle cerebral artery strokes, we have up to approximately 8 hours. So we've extended that window, we've almost doubled that window. So for up to 8 hours, we have the ability to go in and remove these clots, again, from the time the patient was last seen normal to the time we've evaluated and identified and treated that patient. We have up to 8 hours. And we know in that time window that patients have significantly improved clinical outcomes compared to patients who we don't offer that treatment. So again, in that first 8 hours, there should be that strong sense of urgency that there is a patient that you have that you can get somewhere quickly enough, and we can do something quickly enough to fix. Now, the most recent literature that we have is a study called the Dawn study, which was just published, which has even expanded that window out even further for a set of patients that meet certain clinical and imaging criteria for up to, we call it the Dawn study, so we equate that with wake-up strokes, and that's probably the patient population that it most appropriately fits in with. But it is actually not only wake-up strokes, but any patient that has been seen normal within the last 24 hours. So there are patients that we find, it's not that they woke up, but we find in the bathroom. We don't know how long they've been in the bathroom. The last time someone saw them was 18 hours ago, and they could have been in that bathroom anywhere from 18 hours to 1 hour, and we don't know. So anywhere within that last 24 hours, if a patient is having a stroke, there is a possibility that that patient meets the criteria for a treatment that can make them better. So any time in that time period, we're really trying to educate first responders, the EMS, the family members, that all of those patients need to be treated with that same urgency that historically we've treated those patients that we found in the first 90 minutes or the first 3 hours, because there are, again, very time sensitive. The damage to the brain doesn't slow down after 12 hours. It's still, 2 million brain cells per minute. So that urgency should continue until we've made absolutely sure that that patient doesn't meet the criteria for one of these treatments that we now have available.
So would it be fair to say, and correct me if I'm wrong here, but for us as EMS providers and people who are seeing these in a sort of a less controlled environment, we're out in the house or wherever it is we meet them, that the take-home message out of this is that things are changing, and if people have stroke symptoms, treat them like they're fresh strokes. Certainly make the folks who are going to see them later on down the road, and by that I mean the hospital or wherever the receiving facility is, aware of these time frame issues. But for us, people that have stroked 8 hours, 12 hours, up to a day, still treat them as urgently as you would the fresh strokes, because there may be help that we can get them. They're not write-offs, maybe, for want of a better way of describing it, that we used to think they were. Would that be a fair assessment to tell folks?
That would be a very accurate way to describe it. And I think that it's something that, because everything continues to change, I spend way too much time in meetings, in administrative projects, trying to figure out ways to make sure that every patient that ends up in our hospital, and I know this is the same at every hospital around the country, that every patient that ends up in that hospital gets the opportunity to get the treatment that's going to give them the best chance of getting better from this disease. And every month, every 6 months, every year, there's new data that comes out that allows us to expand that application. And the education that I would offer to the first responders is that probably just about everybody that you find that's having stroke symptoms is a potential candidate
For
some form of therapy, and there should be that thought process that that patient is a treatment candidate until proven otherwise. And the way to prove it is to get them into the hospital, get them on the CT scanner, do the imaging that we need to do, and identify that. Using that sense of urgency, we're going to find that we're treating more people than we've ever been able to treat, and people are going to get better at a rate that we have never seen before.
So just sort of finishing up here, I'd like to give you an opportunity. I mean, that's all good information, and I think to a great extent, especially the windows being opened up, and people that we would have otherwise thought maybe hadn't got a lot of therapy available to them. People should know now that everybody who looks like they're stroking take care of them as if they're acutely stroking, and then we can inject them into the system, and then we'll figure out what's going on with them and what or if of any of these treatments are available to them, but at least give them the best opportunity to get the most aggressive treatment that's appropriate for them. But just in finishing up, if you were to have your wish list and you were to say, EMS folks, the best thing you can really do for these people, I'd love to see everybody concentrate on this. What would that be?
Well, Tom, that's a very short and I think a very easy wish list from my standpoint. I think one of the things that has been convincingly demonstrated through our literature is that the sooner the hospital that's receiving that patient knows that they have a stroke alert coming, the more reliably that hospital is ready to manage that stroke, and the faster that patient gets through the system and the better they do. So, from the standpoint of the first responders, the sooner that a first responder identifies a stroke and, as importantly, conveys that to the hospital they're bringing the patient to, the better that patient's going to do as a general rule. And so early identification, early notification of the hospital that the patient has a stroke, those are by far the two most important things. Now, as we learn more about this and develop these stroke severity scales that we can identify in the field, like the RACE scale or the VAN scale or the FAST ED scale, all these various things that we're trialing around the country, understanding a little bit more about whether that patient's going to be a small stroke or a big stroke or a mechanical thrombectomy patient, those are all very important things too, and things that we will focus on in the future. But realistically, just that basic piece of information that there's a stroke patient coming to the hospital is an incredibly powerful and important piece of information to have. A couple other things that it's nice to know that's very helpful in the triage of these patients is if you can identify when that patient was last known well, if you can get a piece of contact information from an emergency contact or a family member that can help give us more history or can help us with the consent process. Those things are obviously other things that are very important. And then just a realization of some of the things that you're going to see as an EMS provider. You and I have talked offline about this. You know, most of these patients are going to have high blood pressure. You're going to take their blood pressure and you're going to be kind of wowed with how high their blood pressure is. I think it's important to realize that a lot of that elevated blood pressure is physiologic, and being too aggressive about lowering blood pressure before they get to the hospital can actually be detrimental to these patients and hurt them because they're using that blood pressure to perfuse the brain. And so I think recognizing the patients having a stroke in the setting of high blood pressure should sort of alert you to the fact that you don't want to be too aggressive about managing that, because that's a protective mechanism that the body has to protect the brain. And we want to allow that to some degree. So those are the things that I think if those can be implemented on a wide scale are things that will significantly impact patient care for the better.
So there you go. Quick rundown on stroke, the newest things that are happening. Obviously, some of the things that have come out here obviously have been the opening of windows, the patients, the time frame, certainly trying to get that as accurately as you can, but knowing that these wake-up strokes are these people that may be hours out that we normally really didn't hold a lot of hope for them getting a lot of therapy at the hospital. There exists a window now for those folks to do better, and knowing that this is such a devastating disease, any amount of improvement in how you're going to live your life after you've had your stroke is an enormous thing, and to a great extent how well we do these notifications and how seriously we take these people really has a great effect on how well they do in the long run. So we'll go on again and we'll do one more of these with medical. I'd like to thank a couple of people, as I've done previously. Hoopla Media have done these videos for us, and a particular thanks to Lifecare Medical Transports, who supported us financially, and we would not have been able to do this in any way without them. So we'll come back again and we'll take on the topic of medical patients, and we'll see you then. Thank you.